Good afternoon. My name is Mac Elid, and I'm an interventional cardiologist at Mayo Clinic. And I'm joined by my friend and colleague, Dr. Kevin Greason. He is a cardiac surgeon with nearly 30 years of experience and has been involved in transcatheter aortic valve replacement since the beginning of this therapy. And so today we're excited to be talking about transcatheter and surgical aortic valve replacement, and we'll look forward to the discussion with our audience. And we're going to start out with a presentation by Dr. Grayson. Right?
Thanks, Mac. We put together a few slides just to kind of highlight what's new in 2024. Most of what's new is with the transcatheter procedures. Neither Mac nor I have anything to disclose, so we're not going to be talking about any off-label things here. So what we have now, I think this is the fourth or fifth generation valve, the Sapien X4 valve. This is from the Edwards lineup, and this is the new valve here. And a couple things about it: it has larger cells here so that it will be easier to access the coronaries, and it also has an enhanced outer skirt. This valve is loaded, is pre-positioned on the balloon, and we're part of the study with that. And so far, we've had a pretty good experience with it, and we're looking forward to seeing, how this is going to fare it out. Hopefully we'll have less perivalvular leak, and somehow, hopefully we can also lower our pacemaker rate. This is the new Evolute FX valve. It's also available commercially now, and it allows for cusp alignment. We also can do the cusp alignment with the X4 valve, and they've also redesigned the delivery device here, so it's a little bit more user-friendly, and we've been able to have actually great control in positioning the valve as far as depth below the aortic valve annulus. As far as recent publications, the Notion trial came out with their 10-year outcomes. This is a study that we've been following. 280 patients were randomized either to transcatheter valve, and that was the core valve, early version of that, or surgical aortic valve. And now we have 10-year follow-up, and this slide here shows the composite outcome here in mortality, and you can see there's really no difference. The main difference is shown down here in this slide, that there was a higher risk of structural valve deterioration, as noted here in the blue line, in the surgical aortic valves. And most of this was driven by severe structural valve deterioration. So that would be an increase in the transvalvular gradient of more than 20 millimeters of mercury, and also to over 30 millimeters of mercury. I would point out that if you go back to the original Notion trial, you can see these are the surgical valves that were put in, and I would say that a lot of these valves are not very good valves. The trifecta valve and the mitral flow valve, we know that they have early degeneration, and the Epic and the Mosaic, these valves tend to have a little bit less hemodynamic they don't have as good a hemodynamic profile as the Peri-Mal valve. In spite of the higher incidence of structural valve deterioration, though, biological valve failure was not different between the two valves at 10 years. And biological valve failure is measured by did the valve dysfunction cause death, or did you have to replace the valve? In this study, the authors concluded that the risk of major clinical outcomes was not different 10 years after treatment, but that the risk of the severe bioprosthetic structural valve deterioration was lower in the TAVR group compared to the surgical aortic valve group. But the biological valve failure was similar. We also have data from the recent Partner 3 trial, 5-year outcomes. This study was recently published in the New England Journal of Medicine, and this looks at about 900 patients that were randomized to surgical aortic valve or TAVI. And this is the 5-year outcomes here. This is a composite endpoint of death from any cause, stroke, or repeat hospitalization. And you can see that there was no difference in the two outcomes now, p-value of 0.07. Bioprosthetic valve failure was also similar in the two groups, as shown here. And this just breaks it down a little bit more. And you can see that there was really structural valve deterioration was no different between the two groups as shown here. And I would note that the bad surgical valves were used in about 29% of the patients in the SAPIEN or in the S3 Partner 3 trial. The authors concluded that among these were the low-risk patients with symptomatic severe aortic valve stenosis. There was no between-group difference in the composite or individual outcomes between TAVI and surgery. So this is kind of how we would put it all together at our institution. We think that the outcome of death is similar between TAVI and surgical aortic valve replacement. Same with stroke. Obviously, there's less morbidity associated with the TAVI procedure, and that would be like renal failure, respiratory failure, less bleeding. Pacemaker rate is higher in the TAVI procedure, so it's less in the surgical aortic arm, at least in our experience. And obviously, pain and recovery are quicker with the TAVI procedure. If I tell patients if things go well, you might be better and out of the hospital in one day. It's unclear about durability, but at least out to 10 years with the NOTION trial, we're not seeing a major signal that bioprosthetic valve failure is different in either of the two valves. We did look at our experience here at the Mayo Clinic in patients that had TAVI between 2013 and 2020. And what we found that there's often quite a bit of comorbidity that comes along with surgical aortic, symptomatic severe aortic valve stenosis in the group. You can see here that any significant coronary disease was present in almost 70% of patients, and this included a proximal LAD stenosis in 18% or a left main stenosis in 13%. In addition, atrial fibrillation, 42% of patients, important mitral valve regurgitation, so that would be moderate or more, 30%, mitral valve stenosis, 26%, and tricuspid valve regurgitation. We put these comorbidities up here just to highlight that, these are things that we can take care of in the operating room. So when we see patients that have symptomatic severe aortic valve stenosis and these factors here, we're kind of already thinking that, this is somebody that we need to have a little bit more of an in-depth discussion about the differences between TAVI and surgical aortic valve replacement. In summary, we would say that TAVI and surgical aortic valve replacement are four-letter words. You need to choose and use them wisely. Durability remains unknown, but it probably is the same. We don't want to forget about the big picture and certainly don't ignore other cardiac comorbidities. Our sense is that the focus of the operation should be on the correction of the problem or problems, prevention of complications, and the prolongation of the vital status. So with that, we'll complete the presentation, and we will go ahead and open it up to questions and discussion at this time.
That was really great, Kevin. Thank you for that overview of TAVR. And I guess, just on this topic that you closed out with on considerations of surgery, things that we can take care of with surgery, what are some of the most common scenarios where you're recommending surgery over TAVR for a patient with aortic stenosis that you're seeing in clinic?
I think probably the most common one would be an associated valvular problem. For instance, moderate mitral valve regurgitation or tricuspid valve regurgitation. And lately, actually, I think we've seen kind of an uptick in the patients that present with atrial fibrillation. And we know that if we just do a left atrial appendage ligation, let me rephrase that, if we excise it and close it off, that we're going to probably reduce their risk of stroke from atrial fibrillation by about 50% as they go on to live. And that's a huge thing. And I think a lot of patients are surprised when we tell them that that's an additional benefit of surgery. I mean, it's kind of hard to sell an operation sometimes, when you tell them it's going to take you 2 months to get over it. But I think people are smart enough to realize, that there are some intangible benefits to not having your left atrial appendage if you're in atrial fibrillation.
Yeah, and we do want to invite the audience to provide or come out with any questions. And I do see one that just came in. Basically asking us to comment on bicuspid aortic valve stenosis. So this is a common scenario that we see, and we see patients presenting in a spectrum of different ages with bicuspid aortic stenosis. And I would say we use a tailored approach based on the anatomy, based on the age of the patient. Kevin, what do you think about bicuspid aortic valve?
Yeah, I think The standard is that usually these are younger patients that present with their symptomatic severe aortic stenosis. Um, and, part of our job is we're not the doctor police. We're not there to tell them what we can do or they can't do as far as their valve operation is concerned. Our job is to kind of give them the information. And we've had patients who've been in their late 40s who have insisted on having a transcatheter procedure. And we've had patients in their mid 70s that insist on having a surgical procedure. So I think from our perspective, it's just to lay it all out there for the patient so they understand the risks and benefits of it and allow them to make a decision. I mean, I think when you're dealing with the lower edge of the age range, the patients that are under 60, biological valve durability, whether it's a surgical aortic valve or a TAVI valve, those patients are going to be back in 7 to 10 years. And that's something that you really have to have a focused conversation with them about because, there will be issues that have to be dealt with at that time.
Yeah, absolutely. You and I have these discussions with patients all the time in our TAVR clinic, and I agree, particularly these patients that are less than 65 are the ones who stand to benefit from the mechanical valve the most. And also, I think I would add, just when we're looking at bicuspid anatomy, we also look at the distribution of the calcium and how that's going to impact their risk of a transcatheter aortic valve replacement procedure. We just did one recently with no raphe at all, so Sieber's type 0 valve with not too much calcium in the valve, and the TAVR valve expanded very nicely. And that's very different than one that has a very high calcium score and a very calcified raphe.
Yeah, absolutely. I think it's important that we sit down and look at the CT scan together because we each bring a different perspective about what, the risks and benefits of the procedure are. And I would just highlight that the FDA has approved TAVI for patients with symptomatic aortic valve stenosis. It doesn't matter whether it's a bicuspid or a tricuspid valve. So patients are asking for this therapy. And our experience here at the Mayo Clinic is that mechanical aortic valve replacement has better survival than biological valve replacement. And, we tell patients that, but still, they may insist on having a TAVI valve.
And just along those same lines, I mean, the issue of ascending aortic aneurysm with bicuspid aortic valves is a particularly important one. And how do you factor that in when you're seeing a patient? Let's say you're seeing a patient that's in their 60s versus an older patient with an ascending aortic aneurysm, and how does that influence your recommendations?
So it all depends on how big the aorta is. I think if I see an aorta that's over 45 millimeters, we're thinking that we're going to intervene on that at the time of the aortic valve replacement. And that would be an ascending aorta replacement. Certainly, if you do a TAVI, you're not going to intervene on that. Standalone indication to replace the ascending aorta, 5 to 5.5 centimeters. And it would be hard to justify, I think, in my mind, a TAVI in a patient that had, for instance, a 6-centimeter ascending aorta. They would have to have, other comorbidities that would just make an operation, super high risk.
We have another question that came in. This is a really interesting one and very timely. The issue of the smaller annulus. So does the smaller annulus favor surgical aortic valve replacement is the question. What would you say to that?
Well, I think we know that what we're alluding to here is prosthesis patient mismatch. And the prevalence of that is much less after transcatheter valve than it is from surgical aortic valve replacement. We do have something in our armamentarium, though, as surgeons, in that we can cut the ring where the valve sits, and then the ring will open up, and we can sew a patch in there. And now we have a bigger ring, and then we can sew in a bigger valve. That's called a root enlargement procedure. And we're pretty facile with that. And we would do that probably in upwards of 20% of patients. It's a rather simple procedure. It probably extends the cardiopulmonary bypass time by about 20 minutes. We've looked in our experience of patients that have had that procedure, and it doesn't look like it adds anything as far as risk of bleeding or stroke or pacemaker. So I think if we're at all concerned that we may have prosthesis basis mismatch, then we'll just go ahead and do a root enlargement and put in a larger valve.
Yeah, that's important to note that doesn't add any risk to the surgery. That's really I was happy to see that. The other question about the smaller annulus, we just had the results of the SMART trial that were published at ACC, looking at the 1 year outcomes. They looked at both structural valve or hemodynamic uh, dysfunction or structural valve deterioration, kind of that definition that you showed. Although I think theirs was a little bit less strict, looking at a mean grading of 20, higher than 20 was one of their definitions. And then also looking at just clinical endpoints, mortality, rehospitalization at the 1 year mark, and really didn't show a difference in clinical outcomes at 1 year, but the rate of having a high gradient over 20 was about 1/3 in the balloon expandable versus self-expanding valves. What do you think about that?
So I think that kind of makes sense to me. I mean, I think that the evolute valves, they're superannular, and I can put that in my mind and realize that that may give you a better hemodynamic profile in a small root. Um, I mean, we talked about this earlier. One of my concerns with that study is if you go into the supplement, like page 29, you'll see that these were roots that had a diameter of 23 millimeters. Yet I think about a third of these patients in the evolute group got a 29 millimeter evolute valve, and that doesn't make sense to me. Why they would be getting a such a large valve in a small root in a small annulus. And certainly, I think if you compare a 29 millimeter evolute against a 20 millimeter sapien S3, there's going to be a hemodynamic difference there. So I think we need to do an additional study, but
Yeah, that's a really important observation. I think that's one thing that we think about is what is the gradient we're going to have in our patient after we do the intervention. But we also have to think about if they do need another valve later, that's another thing we have to factor in, the whole issue of valve and valve. And the feasibility of that might be different depending on what kind of valve we put in.
yeah, I mean, no one would be excited about doing a valve inside of a 20 millimeter S3 valve, you know. I think you could do it inside of a 23 evolute,
Mhm.
that would be right.
Great. Looks like we have another question about the presence of mitral regurgitation and how does that change after we perform transcatheter valve implantation compared to surgical aortic valve replacement? So does mitral regurgitation get worse after transcatheter valve implantation compared to surgical aortic valve replacement? So that's an interesting question and probably depends on the mechanism of mitral regurgitation. If it's secondary mitral regurgitation due to LV dysfunction versus primary mitral valve disease. What has your experience been with that?
I mean, intuitively, you would think that if you release the pressure pop-off valve of the aortic stenosis, that the pressure in the LV is going to go down and mitral regurgitation should get better. Kind of my experience is about 50% of the time, it doesn't really change much. 25% of the time, it'll get better. And maybe 25% of the time, it might get worse. Now, that's just with an isolated TAVI procedure. In surgery, I mean, if you have moderate mitral valve regurgitation, I think most of us are going to go after that at the time that we do the aortic valve. And if it's just degenerative or even functional, if it's moderate, probably a ring annuloplasty is the only thing that you would need to have done. And I think that there's probably a good 90% chance that that's going to reduce the mitral regurgitation to trivial and I mean, I would be a proponent of that, an aggressive stance on dealing with mitral regurgitation.
I agree. I think in most cases, if it does improve, it's only by a small degree. Even in secondary MR, which is really load sensitive, and it will get better acutely if you unload the left ventricle, you'll still have persisting MR that's going to progress over time. So you still have to really follow that closely if you do a TAVI on the patient. So I completely agree with what you were saying. Let's see. Here's another question. Please comment on the incidence of pacemaker following transcatheter valve replacement, and as you suggested, may be reduced with the new valve type. And how do you assess in clinic pre-procedure the potential need for a pacemaker? So lots of good questions there. So yeah, I could start with that. So I think the new valve types, I think what we're seeing now is actually our newer techniques, and I'll be interested to see if you agree with this, but this newer technique of implanting the valve higher than what we have done historically does seem to be reducing pacemaker rates in our experience, and also what I've seen in retrospective studies. And then also, how do we assess that pre-procedural need? Well, we have this algorithm that we look at, looking at their ECG. We also look at membranous septum length, although that you can't really change the membranous septum length for a patient, so that's a non-modifiable risk factor. The one thing we can change is how we implant the valve in the actual procedure. So we have a simplified algorithm we look at, which stratifies patients into group 1, 2, or 3, and that helps their post TAVR management. What do you think?
So I think technology is going to help us in this with this problem. If you look at like the Evolut FX valve, the we can implant that pretty regularly around 1 millimeter below the annulus. And we didn't have that kind of control before. So I think that that's an important thing. We use the custom overlap view. Everything's optimized to put the valve so it's just right where you want it. And I think that'll have an important impact on our pacemaker rate. I think it's important to understand that it's not just complete heart block that happens right at the time of the procedure, but we've seen patients that have had sudden death a week, 2 weeks after TAVI procedure, when they had a narrow complex QRS rhythm in the hospital, and they went home and they had sudden death. And you can't figure out why that would happen. And probably related to acute onset of complete heart block. So we tend to be a little bit more, I think, conservative, and we tend to put in a pacemaker rather than not put in a pacemaker. Our pacemaker rate's probably around 15%-ish right now, I think. Would you agree with that?
Yeah, I think that's what our rate is, and I agree. I mean, we've looked at this. We're continually looking at our experience, and we just recently studied the patients who have right bundle branch block who did not have an immediate ECG change after TAVR, looking at, okay, well, what is the rate of subsequent block in those patients? And even if they didn't have complete heart block immediately at the time of the TAVR, they had an 18% chance of having delayed high-grade AV block with that pre-existing right bundle branch block. So that just kind of emphasizes the importance of following these patients when they have high-risk ECG features.
Mm-hmm.
So, so definitely something that's in flux. And there's systems that we're participating in a study of a monitoring system that helps us in real time during the TAVR procedure look at signals during the procedure that might tell us a patient's at a higher risk of getting progressive AV block, and that might allow us to modify things intraprocedurally based on that feedback that we get just using ECG monitoring that's shown to us in a easy to understand way or easy to see way on our monitoring screen. So lots of work being done in that area.
I think we've had a couple people that will try to reposition the temporary pacing lead into the atrium and do rapid atrial lead pacing at a rate of like 120 or something like that to see if you get conduction loss at a faster rate. But I haven't really gotten comfortable to the point where I would make a decision on whether I'm going to put a pacemaker or not based upon, how the patient would respond to that.
Yeah, I think that's a useful tool for what's happening right at that moment with the conduction, looking to make sure that they have good AV conduction. But what we've seen, even if you have good conduction at that moment, you can still get delayed AV block in a patient. So I think that doesn't take away the need to monitor the patient. Yeah.
And just putting the stiff wire across the aortic valve, we've seen patients go into complete heart block just by doing that.
Absolutely.
So it has to be a pretty tenuous or a very fragile, area of the myocardium. So
that's right. I mean, aortic stenosis is kind of a degenerative disease, and so there's a lot of things that come along with that.
Well, if there's calcium in the valve, there's probably calcium in the conduction system too.
Yep. So great questions. Please keep those questions coming. Here we have another question. So about the life expectancy of a biologic valve. So this question, did you say that the life expectancy is only 7 to 10 years, regardless of a surgical or transcatheter aortic valve? So maybe we can clarify what we think the life expectancy is of biologic valve.
Yeah, so that would be like in a 50-year-old. So the life expectancy of a biological valve is directly related to how old you are when you get the valve. If you're 85, chances of you wearing out a biological valve are about zero. But if you're 50, or if you're 30, if you put a biological valve in a 30-year-old, you're going to probably get 5 to 7 years out of it. So it's age related. But I think if you're talking about, say, the 65-year-old patient, that's going to probably be 10 to 12, 15 years. And then you're going to start to see valve dysfunction. Now, that doesn't necessarily always turn into valve replacement. But, one of the thoughts of why people die who have biological valves have worse survival than patients that have mechanical valve is that they probably lived the last several years of their life with moderate severe aortic stenosis or moderate severe aortic valve regurgitation, and that probably expedites their demise.
Yeah, that's a good point. And I think there's also immunologic factors. There's some patients who have thrombophilias that are not fully understood, or some patients can get subclinical thrombosis of the leaflets that isn't necessarily detected. We see that in up to 30% of valves if you're just doing screening CTs in everyone. So we have to learn more about what are the things that we can identify up front in a patient to help predict which patient is going to have that problem, because then a patient like that might benefit from anticoagulation and a different type of valve, like a mechanical valve, potentially.
Absolutely. I think somehow hyperattenuated leaflet thrombosis probably does lead to premature valve senescence, and failure. And you wonder, if you put all those patients on, say, a DOAC, that's probably a pretty well tolerated medicine as long as they don't have a bleeding problem. Maybe their biological valve would last longer. I don't know the answer to that one.
Yeah. I mean, I think that's one of the reasons why our approach has been to place patients on anticoagulation for the first 3 months after either transcatheter or surgical aortic valve replacement. And we do a tailored approach, though, for patients that are at a higher bleeding risk. If they meet high bleed risk criteria, then we would allow antiplatelet therapy after TAVI. So that's how we approach the anticoagulation afterwards. Looks like another question here. If you have difficult access for transcatheter aortic valve implantation, does that favor surgical aortic valve replacement if a patient is a reasonable risk for surgery? So, yeah, interesting question. So difficult access for TAVI, does that favor surgery if a patient is reasonable surgical risk?
In my mind, it does. I think if you're talking alternative access, we're already talking that a lot of the benefit of TAVI may not be there. And I would lean towards surgical aortic valve replacement. But there's a group that are not great candidates for surgical aortic valve replacement, and then you're willing to do transcatheter procedure. I think probably about 5 years ago, our alternative access was maybe 1 or 2%, but it has come up now. It's probably about 5%, I would say, right now. And I think we're doing a lot of transcarotids. We don't do as many transaxillaries, and I don't think we've done a transapical probably in, probably 5 or 7 years. But that's probably how I would look at that.
Yeah. Yeah, my first impression of that is it's unusual that if a patient doesn't have good femoral access, then they're typically not going to be low surgical risk in most cases, but occasionally a patient like that does pop up. But I agree. We've seen quick recoveries and good outcomes with the transcarotid that's probably our go-to for alternative access at this point. Looks like another question came through. And any thoughts about Resilia tissue valve and better durability? So the Resilia tissue, that's what the new Sapien X4 has on the leaflets, and also there's a Resilia Sapien 3 Ultra valve. So what do you think about that, Kevin?
Well, that's the new secret sauce, and anything they change is going to last 5 years. So the proof will be the 10-year data. And unfortunately, we don't have that. I mean, with the Edwards surgical and spurious valve has this Resilia treatment too, and the 5-year data on that looks good. But even the 5-year data on the trifecta valve looked good. So we need to be patient on that. I think it'll be 10 years before we have any signal whether it does anything or not.
And the 5-year structural valve deterioration from PARTNER 3 was relatively low.
Yes.
It was, so even without the resilient tissue, that rate is relatively low. So it'll be interesting to see how that bears out. Great questions. Another one came in, the question all patients ask, Doctor, what would you do if it were you? And what would the panelists do if they had severe aortic stenosis? Well, I would do, my algorithm is kind of multifaceted, but I think for most patients with degenerative severe aortic stenosis, transcatheter aortic valve replacement is a great option for most patients in their 70s and beyond who have isolated severe aortic stenosis, I would say. So that's what I would choose. But again, if it's a patient who might benefit from a mechanical valve, if it's a patient who has an aortic aneurysm or critical multivessel coronary disease with diabetes that would benefit from CABG, those are some examples where I would do surgery. But if all it is the aortic stenosis and you're in your 70s or more, generally TAVR is a good option. What do you think?
I agree. I mean, if it's just aortic valve stenosis and they're 75 years of age, then I'm totally on board with offering a transcatheter valve in that situation. If they're 60, I'm totally on board with offering them a mechanical aortic valve replacement. It's all age related. And, the other thing you have to throw in there is, what is their lifestyle? I mean, if they're in AFib and they're on Coumadin, that makes it easier, but if they're living a life of downhill skiing and doing other, quasi-dangerous things, maybe being on Coumadin is not a great thing for that patient.
Absolutely. So that discussion about anticoagulation is one of the most important ones. And I try to give patients kind of estimated yearly bleeding risks of being on anticoagulation, risks of thromboembolism related to the mechanical valve based on the data that we have. And that can be helpful too in helping them make a decision. But that seems to be one of the biggest factors when we're having that discussion with our patients.
Yeah.
So, I mean, just looking back, we're waiting for other questions. Looking back at the last 10 to 15 years, how would you say that both transcatheter aortic valve replacement and surgical aortic valve replacement have changed? How have these therapies evolved in the last 15 years, would you say?
Well, I think the TAVI is the easiest one because, we have 5th generation valves now. We have the F22 Raptor type valves, and access size has gone down significantly. When we were first putting these in, it was 24 French, and, now we're down to 14. That's a huge difference. And I think probably 95+% of the patients we see in the TAVI clinic are candidates for a transfemoral procedure based on the smaller sheath size. So I think that's probably the most important thing. I'm not sure if all the secret sauces and the valve design changes have really had an impact on valve durability. It seems like every time we get towards 5-year follow-up, we've got a new valve now. So I don't know that we'll ever feel comfortable with seeing what the durability of a valve is. But as far as surgery is concerned, I think one of the biggest developments in the last 10 years has been the awareness about prosthesis patient mismatch and, getting out of the OR with a good size valve and doing a root enlargement if you need to. In Rochester, we tend to favor mechanical valves. Our experience is that patients live longer with mechanical valves and that the risk of stroke is no difference, whether it's a biological valve or a surgical or a mechanical valve. And so, if I have a patient, it doesn't matter what age they are, if they want a mechanical valve, I'm usually pretty happy about putting that in.
And could you just briefly describe what a Ross procedure is and also just what the general approach is at Mayo for the Ross surgical procedure?
So the Ross procedure is a pulmonary autograft where you harvest the pulmonary root and you transfer it over to the aortic root, and then you put in a cadaver root in the pulmonary position. And our take on that is that it's probably something that is useful in probably the young patient that has aortic valve disease. And that would be probably somebody certainly under the age of 50, but maybe less than that. There are some detractors of the Ross procedure. You take a one valve problem, or you take a left-sided heart problem, and now you're going to make it a right and left-sided heart problem. And that can be a problem. And the conduits, the pulmonary conduit at some point will have to be revised. And that has its own set of issues. There was a recent paper out of Yale, and they looked at mechanical aortic valve replacement, and the long-term outcomes of that study were excellent. And I think the survival approach that of age-and-sex matched controls. So mechanical valves are not a bad option.
The thoughts about aortic stenosis with moderate aortic regurgitation. So I guess thresholds to intervene. So I think, one common question that we see, if a patient has both moderate aortic stenosis and moderate aortic regurgitation, should we be intervening on that patient? And there is some data, including a study from Mayo, showing that those patients benefit from earlier intervention if they have mixed moderate AS and AR. So my approach has been to look at whether the patient's symptomatic. If we think they're symptomatic and there's no other cause other than the valve, then I would typically recommend intervening. What do you think?
Absolutely. And I think that's easy to do surgically. You're in a little gray zone, transcatheter, because, the FDA and CMS say it has to be severe aortic stenosis. So you always have to give the patient kind of the warning that, I said we were going to talk about off-label stuff, but that may be a little bit off-label.
Yeah.
If it's not severe AS. And we've never had, as far as I know, CMS or insurance company kickback reimbursement claim for somebody that we did TAVR in who had even aortic regurgitation is the indication. But I suspect it could happen.
So here's a question, and of course related to that, also just moderate aortic stenosis. We have a clinical trial that we're enrolling patients in, looking at patients who have heart failure symptoms and only moderate aortic stenosis, whether TAVI versus heart failure medical therapy improves outcome. So that'll be interesting to see the results of that. So that's the EXPAND trial. There's other trials also that have already been completed in enrollment. So we'll have more data on whether we should be intervening sooner on moderate aortic stenosis, and that'll be good to see. Here's another question about aspirin use in patients who have a mechanical aortic valve who are already on warfarin. If we look at the guidelines, recommend adding low-dose aspirin to a patient who's on warfarin with a mechanical valve. And there's some pretty old data that shows that can reduce the risk of pannus formation. But I really tailor that recommendation based on the patient's bleeding risks, because if it's an elderly patient, adding that aspirin to the warfarin really drastically increases the bleeding risk. So I think we simultaneously have to look at the bleeding risk of the patient. But in a perfect world, yes, we would have aspirin with the warfarin. Do you have any other thoughts about that?
Yeah, we add the aspirin in the hopes that we can run the INR towards the lower end of the range. There was this recent study with the Onyx valve, seeing if you could even just do a DOAC, and that kind of fell through. The risk of thromboembolism was higher with the DOAC. So, but certainly as relates to this question, I think, aspirin with Coumadin is a good option in most patients, and will allow us to run the INR a little bit lower.
Great. So is there an indication for transcatheter aortic valve implantation in an asymptomatic patient who has severe aortic stenosis, or do we have to wait for symptoms to occur? What do you think?
Well, I don't think that's not FDA approved, but the way we deal with that is we put these patients on the treadmill and do a cardiopulmonary exercise stress test on them, an oxygen consumption study to see if they have a cardiac impairment. If they do, then we say that that's a surrogate of symptoms. And I think if you just sit down and you talk to the patients in depth enough, like, what were you doing 5 years ago and what are you doing now? Most of the time, you can see that there has been a kind of a gradual decline in their level of aerobic activity. And certainly in the setting of a positive cardiopulmonary exercise stress test, I would say that that equals NYHA class 2, and I'd be willing to move ahead.
Yeah, yeah, I think that reflects our practice. I think the other thing is if they have the hypotensive response to exercise, that's the other thing that we look at as another marker of the cardiac output limitation. Um, and we were just talking earlier about there is a randomized trial that completed enrollment, the early TAVR trial, which that'll be interesting to see because they randomize patients with asymptomatic severe stenosis to either TAVR or waiting for the onset of symptoms. So it'll be good to see the results of that trial. But there's more and more evidence that is suggesting that maybe we're waiting too long to do TAVR. But for now, though, it's still you do have to wait for symptoms or an abnormal stress test to do it.
Mm-hmm.
Yeah. So what about transcatheter aortic valve implantation for severe aortic regurgitation without aortic stenosis? So what do you think about that?
Well, that's probably the one thing we argue about the most.
Yeah.
So those we've done it and we've got good results. We've even done it in patients that have like an LVAD. So these are ones where you really need to sit down and look at the CT scan because you're not going to have the stenosis in the valve to anchor the valve. So you're going to, if you use the evolute valve, you're going to rely on the aortic root and the ascending aorta and how big that is. You have to be prepared to kind of do the double whammy, the evolute followed by the sapien if the evolute moves. So you have to be ready to intervene on that quickly. But we have done that.
Absolutely. Yeah, I think our experience has mostly been with off-label TAVI in that situation using the self-expanding valve, and we look for 15 to 20% oversizing when it's a non-calcified pure aortic regurgitation, and the need for the second valve has been somewhere in the 10 to 15% range in our experience. So most patients we can get by without placing a rescue second valve, but it's an important added risk of doing that. But the dedicated aortic regurgitation valves are moving along. There's the JenaValve and the J-valve, and the JenaValve high-risk trial was completed, and it's expected that might become approved for high-risk surgical patients sometime in the next couple of years here. So that might be commercially available. And I think they're also planning an intermediate risk surgical versus TAVR trial for these aortic regurgitation patients. So that'll be interesting to see, since that has a different kind of a fixation mechanism where it actually directly fixates on the leaflets.
Yeah, in my experience, the patients that present with just pure aortic regurgitation usually have rather large annulus. And that can make, the transcatheter procedure a little bit more dicey because you may not have that oversize. And I know recently we had a patient that had oversize of only about 8% for the LVOT, but the patient had a microprosthesis. So the microprosthesis was kind of a bookend that we could put the evolute valve against. And that case actually turned out quite well. So
yeah, I remember that the mitral bioprosthesis was canted so much into the LVOT that provided an added backup. Yeah, we've had a lot of interesting cases together, haven't we?
Yeah.
Here's another question about any experience with procedural outcomes in TAVI with moderate sedation using transthoracic echo versus with general anesthesia and using transesophageal echo. Yeah, that's a good question. I mean, that kind of speaks to the evolution of TAVR that we were talking about earlier. What would you say about that?
Yeah, probably about 5 years ago, our TAVI practice was in the red. And we did them all down in the operating room with general anesthesia with TE. And so we started looking at everyone's comorbidity and their BSA. And we did a kind of a practice change, a quality initiative, where we said, we think these patients are going to be low risk for a complication. Let's move them to the cath lab, and let's do ultrasound guided per close, and we'll do conscious sedation, and we'll do transthoracic echo. And as we did that, we became much more confident in our abilities to get those patients through the TAVI procedure. And so we loosened our criteria for who could have the minimalist approach up in the cath lab, to the point now, probably 98% of our patients are done in the cath lab. They're done under conscious sedation. They're done with transthoracic echocardiogram, and they're done through a percutaneous access in the groin.
Yeah, it's been a kind of a remarkable transition, and patients are still amazed that they can have a valve placed and they're awake during it. We have a lot of team members in the room, so the echo adds, I think, to the quality in terms of they're there immediately in case there's any question about any issues, during the procedure, and can also just help us get a nice paravalvular leak assessment immediately. And it's been nice to see those rates of paravalvular leak dropping over time, so that in general TE, which that would be the main advantage of the TE, is that you could see paravalvular leak in even more detail, particularly posteriorly located. But it's rare now that we really need the TE during a TAVI.
Yeah.
Another question about combining percutaneous coronary intervention, PCI, with TAVI, or so doing it simultaneously or separately. And we've done it. We have done combined PCI with TAVI in various scenarios. When, for instance, if we wanted to expedite the treatment, but we also, in many cases, are not treating coronary disease as much as we were historically. What do you think about just the impact of coronary artery disease on the health or the long-term outcomes in these severe aortic stenosis patients?
I think we've backed off of that cause and effect type issue that we say we had like 10 years ago when we started doing these. I mean, if you had a 50% lesion, you probably receive PCI before we do your TAVI. Now we look at every coronary lesion. We're like, does this patient have angina? Where is that coronary lesion? If it's a proximal LAD stenosis, we would periodically be more inclined to deal with that. But if it's a OM or PLB, a lot of times we just do the TAVI. Let's see how the patient does afterwards, and then we can always come back and restent them. And to be honest, we've seen some patients that we've had TAVI done probably 3 to 5 years ago who now are coming back for coronary artery bypass graft operation because they had a left main that got stented, and now they've got in-stent stenosis. So, I'm not sure how all that's going to shake out down the road, but
yeah, I think generally we don't do them combined, but and it's very uncommon that you would have to urgently do PCI after TAVI. But I think the exception there would be our patients who are valve-in-valve TAVI with a high risk of coronary occlusion, where we protect the coronary artery. So, all right, another question about, do you see potential for artificial intelligence algorithms to enhance your ability to predict post-procedural complications and long-term outcomes for transcatheter and surgical aortic valve replacement patients? So can AI algorithms kind of enhance our predictive ability for particularly post-procedural complications for long-term outcomes? I think there's a lot of potential there. Particularly, there's a lot of interest in pacemaker risk, what we can predict before the procedure. For instance, if a patient is at a 90 to 100% risk of needing a pacemaker with TAVI, it might be preferable to place a pacemaker beforehand. And artificial intelligence could add a lot there by integrating all the data that you can get from imaging and other variables. What do you think?
Yeah, I think that would be a great option. The other part of the equation, I think, though, is with root rupture. Now, root rupture is very uncommon, maybe 1 out of 200 or 300. But I think AI may be able to help us in as far as like, figuring out how the valve is going to sit in there and, where's the calcium in the aortic annulus and are the two going to interact and is this going to be a problem?
Yeah, that's really an interesting. There's some software, right?
Yeah, I
That
think
can
Dr.
model
Holtz
that.
has talked about that,
Mhm.
and so it'll be interesting. I mean, fortunately, that complication is very rare, but nobody
Mhm.
wants it.
Yeah, I mean, if that could be embedded into our assessments, and that data is readily available, that would be great for avoiding that rare but certainly catastrophic
Yeah.
complication that can occur. Yeah, great questions from the group. So we've talked about a lot of different aspects of both transcatheter and surgical aortic valve replacement, and including the post-procedural management, long-term outcomes as well. Um, any other topics that you wanted to talk about, Kevin, that you can think of?
No, I think that one thing we haven't mentioned is the heart team. And I think our heart team here has been in evolution since the first two cases in 2008. We used to meet Friday mornings and have an hour-long discussion, and we talk about two patients. Now our TAVI clinic is like 7 or 8 patients in the afternoon, twice a week. So, we have to be a little bit more efficient. But I think that that has certainly led to, I think, better management of patients with aortic stenosis. And I know the government required that's kind of been like a forced marriage, a forced marriage, and I hope it continues. And I don't know if any of our government people are listening to this broadcast, but I think that's probably one of the best things that has come out of the TAVI practice.
Yeah, I agree. I mean, I've gotten so much. I know the patients appreciate meeting with experts in both surgery and interventional techniques, and then but I've also just learned so much by being able to work closely with surgical colleagues as well. So I think it's done a lot of good things all around to have that approach.
Yeah.
Absolutely.
I mean, we each bring a different perspective
Right.
to the CAT scan, like reviewing the CAT scan, because
Yeah.
things that are important to you
Yeah.
are not necessarily important to me, and vice versa.
Mhm.
So I mean, I think it's been a good thing.
Here's been another question about what has your experience been with valve and valve TAVR for degenerative valve problems? So this is a common scenario. A patient will come in with either progressive stenosis of their biologic valve or regurgitation as well. So, and we've done a lot of patients with this, both with surgical valve deterioration, less so with transcatheter valve deterioration. What is your general approach, Kevin? Is that usually your standard? Is if they come in with bioprosthetic valve dysfunction, is TAVI going to be your first choice?
What I do is I go back to the first post-op echo, and I see what kind of a gradient and an EOA they had at that time. If the patient had prosthesis or prosthesis patient mismatch, you know, 6, 7 years ago when they had their valve in, then I'm not probably going to say let's do valve and valve in that situation, unless it's somebody who's high risk and has a pure aortic regurg problem now. But I usually like to go back and look at that first echo to determine where I'm going to go with this conversation. If their first EOA was 1.1, that's going to be a good patient for valve and valve. And I'll just lay it out there to the patient. But we've looked at our experience here too with repeat surgical aortic valve replacement and TAVI valve and valve. And the problem with the TAVI procedure is there's a pretty high incidence of uh, prosthesis patients mismatch after valve and valve. So you have to choose the right ones. And in our experience here in Rochester, the mortality of a redo aortic valve replacement is the same as a primary aortic valve replacement.
Yeah, that's huge. And you're saying indexed valve area of 1.1 in that example, right?
Yeah, right, right.
Index,
Yeah.
yeah, absolutely. Yeah, so that I think that's a huge factor is what was the baseline element of patient prosthesis mismatch. Absolutely. And also the coronary occlusion risk. I think that's one of the factors sometimes that will lean us more towards surgery too. If we have a patient who has a very high risk of coronary occlusion with valve and valve, occasionally that'll be another reason that we'll recommend surgical aortic valve replacement. Um, so, so how many TAVI patients are discharged the next day or in less than 24 hours? So I can say, from our practice, it's over half of our patients are discharged within 24 hours after TAVI. Do you have any other thoughts on that?
I mean, if they have a pacemaker, they could probably go home the same day,
Right.
But I don't think we've actually done that yet. But
We have in just a small number. It's
mm,
generally going to be the patients who already have a pacemaker. We're not worried about pacing risk, or they have a completely normal ECG post TAVR. And also they have to be comfortable with that as well for same day dismissal. And so those are generally on the younger side of our patients that are going to be more comfortable
yeah,
and have a lot of support. Yeah.
and it is a pretty big hole that you put in the femoral artery, and maybe 23 hours of observation isn't a bad thing, just to make sure that
Right.
everything looks good.
So do you follow up all TAVI cases, or do you receive communication from local cardiologists about echo assessment? So we all of the TAVI patients have a follow-up at about 30 days. And whether they do that back with us or they do it locally and we get the images will kind of depend on the patient's preferences. But we do make sure we get that information. Whether or not they are physically following up with us or um, absolutely, it's super important. And we also send them their kind of questionnaires as well if they're not physically following up with us, so we can see what their quality of life is. And generally, we're seeing improvements afterwards. So
I mean, don't the guidelines recommend, like, if you get a artificial heart valve, you should have an echo every year?
essentially, I think that's now
Yeah,
reasonable. It used to
yeah,
be, you had to wait even longer, but I think
yeah.
that's generally our approach is to do an echo on a yearly
Yeah.
basis. Yeah.
I mean, I tell patients we'd love to have them come here every year, but if they don't want to, if they live far away, then they should get an echo with their local cardiologist every year, and they should include us in the conversation, so that we can, deal with issues, and certainly it helps us with knowing what our experience is as far as, what we would recommend down the road.
Absolutely. Um, there's been a lot of great questions. I don't see any additional questions here. Any other last comments, Kevin? We're getting close to the end of the hour.
Well, the only thing that I can say is that, technology is not going to stop. And it would be great to have this webinar again in, 5 years, because we'll probably have the FX Maverick 2 valve. And I always tell patients, it's sometimes it's kind of hard to sell you an operation today based on a technology that you might need in 15 years when your valve wears out, because who knows what we're going to have available. So
That's
I'm
right.
excited about that.
I am too. It's a constantly changing field. So we'll make this a regular occurrence.
That's right.
All right. Well, thank you all for attending, and it's been great talking with you, Kevin.
Thanks, Mac. You have a good day. Thank you, everyone.